Hello, everyone, and welcome to the 2023 Jessamine County EMS RSI DSI in-service training. First, I want to start off by saying that this training will be a little long. I'm going to try to separate it into parts so that it's not exorbitantly lengthy for you. But it might take up a lot of your bandwidth. So if that is the case, then I ask that you take a break if you need to step away and come back to it so that it is more palatable. The quizzes at the end will be difficult, and you will have limited attempts at taking those quizzes. So make sure that you pay attention during the video. All right, and let's go ahead and get started. And first thing I wanted to talk about was the evidence. A lot of people want to know, what is the evidence for RSI, especially pre-hospital RSI, because in the hospital it's kind of well established, but there was a time when people did not want physicians to, or emergency physicians, I should say, to perform RSI. So what I like to ask people is, what is the evidence for using a parachute when you jump out of the plane? And why do we use a parachute? Why not just jump out of a plane and see what happens? Well, of course, they're never going to perform a randomized control trial comparing jumping out of a plane with a parachute compared to jumping out of a plane without a parachute, because that really just doesn't make a whole lot of sense now, does it? So there is some evidence, and I will argue that the evidence isn't necessarily that great. If you look at, the areas that are probably the most studied in terms of pre-hospital intubation overall and pre-hospital RSI are traumatic brain injury and cardiac arrest. And I could have easily pulled some studies showing improved outcomes in both, but I chose to show a study that had mixed results, especially with traumatic brain injury. I would say that the literature in pre-hospital TBI shows that if you perform RSI well, when you're performing RSI, when you're intubating a patient with TBI, then the outcomes are better. Conversely, if you don't do it well, then the outcomes obviously are worse. And in a lot of services where they compared RSI to no RSI, they've compared it to services that previously weren't doing RSI, or they had horrible intubation success rates overall. So you have to take those with a grain of salt. But some do show improved survival if it's expertly performed and if the patient has a more severe TBI. So it's really, really indicated. So there's evidence for that. In cardiac arrest, mostly evidence of harm. In the majority of cardiac arrest studies that you find, there's mostly evidence of harm. But there's some data showing that the outcomes are improved. And here's what I tell people when they ask me about using or intubating patients in cardiac arrest versus drop-in a supraglottic device. How is it different? How is securing the airway with the supraglottic compared to endotracheal intubation different? And my argument there is that it's not, except in this scenario with the supraglottic or with BVM ventilation. You have the option, you can still hyperventilate, but even if I hyperventilate with a BVM or a supraglottic, there's usually a leak. Whereas if I've got a BVM with a PEEP valve, there might not be a leak, and it's not necessarily easier to hyperventilate, but the consequences of that hyperventilation are greater because that pressure stays within the chest. So I like this rock primed study, the Resuscitation Outcomes Consortium, because the EMS services that are enrolled in most ROC studies are high-performing EMS services. So I like to think that if they do well, we also do well. So if you look at the data from a high-performing EMS service and it shows that intubation improves outcomes, then I would like to think that it would improve outcomes at Jessamine County EMS as well. So let's look at another study. And this study was on the incidence of transient hypoxia and pulse rate reactivity during paramedic rapid sequence intubation. And the thing that's interesting in this study is it was a small study. They only had 54% of patients, but of those, they only had 54 patients, 31 of those, which constituted 57% of the patients, had desaturation. That's SpO2 desaturation during RSI. 84%, so 26 of those who desaturated occurred in patients whose initial SpO2 was greater than or equal to 90%. First of all, that tells us that maybe 90% is not a high enough target. All right. 6 patients had marked bradycardia, which they define as a pulse rate less than 50 beats per minute during the desaturation event. What I find most interesting in this study is that the paramedics, the majority of time, they thought that the intubation was easy. They described it as easy, although the patients did desaturate. So it may have been easy, but it was not helpful for that patient for sure. So this is another interesting study looking at the evidence, and you'll see that in this study, the trial included 87 patients. They attempted the intubation in 83% of the patients when the SpO2 was above 90%, and 83% of the patients, only 6% of those, the 83% with an SpO2 above 92%, experienced desaturation to 90%. What I found most interesting out of this study is that 59% of all patients who required more than one attempt, okay, so multiple intubation attempts, had an SpO2 value higher than their initial SpO2 value, okay? So we have to ask ourselves, why was it that the initial SpO2 was lower than when they decided to abort the intubation attempt because they missed it? They did something different, and then on the subsequent intubations attempts, the SpO2 was higher. How could that be? So the reason is that they then ventilated with a BVM. The patient's still apneic, they're still paralyzed. They ventilated with a BVM before they attempted again. And this runs contrary to everything that we are taught with RSI. So with rapid sequence intubation, it goes against the fundamental tenets of performing RSI, which is you don't ventilate the patient. That's why it's rapid, is so that you can immediately provide a sedative, a paralytic, and then intubate the patient. So that's just something to think about. And now we're going to go over part 1, which is the background. So what is RSI? I've already kind of covered that. It is the nearly simultaneous administration of a neuromuscular blocking agents and sedative hypnotic drugs. So generally the sedative hypnotic. We call that the induction agent. Generally, that's given before the paralytic because we don't want to risk for, we don't want there to be any risk of that patient being paralyzed and not sedated. But because of the time of onset and the mechanism of action of those medications, we can give that sedative and then immediately follow with a paralytic agent so that they're both going to be working nearly simultaneously. So, and of course, the purpose is to facilitate intubation of a patient with the least likelihood of trauma, aspiration, hypoxia, and other physiologic complications. Now, RSI does provide muscle paralysis. It reduces masseter tone. So if the patient's clenched or has any trismus, it really loosens that up. And studies have demonstrated time and time again that intubation is more likely to be successful if you use a paralytic than if you use a sedative alone, because you can sedate someone to the point where they're unconscious with a GCS of 3, and it still be difficult because they still have some degree of masseter tone. And the whole point, again, to reiterate, in RSI, in the traditional sense, with the traditional definition of RSI, is to not have to ventilate that patient due to a fear, maybe not really an appropriate fear of gastric insufflation with bag valve mask ventilation. Because, and I have to go back because this paper is arguing that it might be justified and it might be more appropriate to aggressively ventilate this patient. It might be more appropriate to aggressively oxygenate and ventilate this patient with a BVM to prevent hypoxia, because the risk of hypoxia, or the benefits of normoxia, bringing that SpO2 up with a BVM, the benefits of that are greater than the risk or perceived risk of gastric insufflation and regurgitation and aspiration. All right, back to the background. So, you may have noticed in our protocols that there are two different types, if you will, of using a paralytic, okay? There are going to be two different protocols, two different procedures, and you have to determine which patient needs RSI and which patient needs DSI. So when I'm thinking, do I need to use RSI for this patient? Or when do I need to use DSI for this patient? Well, it depends. So RSI we should use on a patient who will permit us to escalate our oxygen therapy. So this is a patient that is tolerating our pre-oxygenation and oxygenation efforts, all right, who's allowing us to either put a non-rebreather at 15 and a nasal cannula at 15, or a patient maybe with COPD who's allowing us to use BiPAP and who's tolerating that BiPAP. We've got the SpO2 up to like 99%. We're able to maintain that for 3 minutes before we push the sedative and the paralytic. We're able to do that, all right? So another example is an obtunded overdose patient that's not reversible, so it's not, they're not responsive to Narcan, but it's some other type of overdose. Maybe they've aspirated a little bit and you think they need airway protection, but they're allowing you to pre-oxygenate. So we're already ventilating them with a BVM. Then that patient would be a good candidate for rapid sequence intubation. Now, what about delayed sequence intubation? So think of delayed sequence intubation as using ketamine for procedural sedation. And the procedure that we're sedating them for is pre-oxygenation. This could be an agitative hypoxic patient, or maybe hypotensive, and you're trying to treat them and they're just not letting you. So we want to administer a dissociative dose of ketamine, IV or maybe even IM, in order to effectively resuscitate them before we try to intubate. And this is kind of how I look at it. There's a small space between the administration of the induction and the paralytic. So for RSI, we would be able to oxygenate them, ventilate them, and then we go sedative paralytic intubation. For delayed sequence intubation, we cannot initially pre-oxygenate them, so we go sedative, ventilation, oxygenation, resuscitation, then paralytic, and then proceed with intubation. So that's how that works. Okay, so here are the complications. Not entirely impossible to avoid if done well. And these complications were probably pretty normal circa 2010, earlier than that, before, when people thought that RSI meant that you had a patient that needed intubation and you didn't need to optimize anything prior to intubating them. Now we know the harm that's associated with not optimizing the hemodynamics and the physiology before intubation. And take a look here, greater at the very bottom, right here, greater than 3 attempts. There was one study showing that the risk was around 10%. So these are avoidable. And if you're in a situation where you think that these are not avoidable, then we frankly would not want to perform RSI on these patients. So if you do a proper risk assessment and you think this patient is likely to experience cardiac arrest if I take away their compensatory ability, and they're not able to breathe during the apneic period, or maybe I can only get the SpO2 up to 60% with BVM ventilation, then, it would not make sense to induce apnea and paralysis in that patient.